Durston, can you hear me in the back? Everything's good. Okay. All right. So, as usual, this is for, well, let's say, entertainment purposes only. No illegal betting or game. I don't know. They always say that stuff whenever you go to things. This is not to be used for illegal gaming purposes. So, I know that was bad. It's the end of a long day. Okay. So there's quite a few slides here, so let me get started on this. So obviously, I'm pretty familiar with this material and what might have happened relative to this. So make sure you understand the parts of the external nose relative to root of the nose, dorsum, ala, so that in particular, if a question were to ask about sensory to any particular part of the nose, external nose, you would know what nerves would be involved. So make sure you understand. I didn't put in there the big picture, but you think V1 going down the root and dorsum of the nose, V2 being out on the lateral, the ala and wherever else. So, and then know the specific nerves, whether it would be infratrochlear, external nasal versus infraorbital on the side. So know the structures of the external nose, so that if somebody said you had a big, huge zit on the dorsum of the nose and pain was emanating from it, you would know what nerve would be responsible for that. Thank you very much. All right, make sure you know that the nasal cavity has a nasal septum inside of it. You know that the most anterior portion of it is made up of cartilage. And then know that two particular things form the nasal septum, that being the perpendicular plate of the ethmoid bone and the vomer. Okay, so those two bony structures form the bony nasal septum. It never hurts to know that on the vomer, on each side of it, encased within the mucosa on the vomer, would be the nasopalatine nerve coming from V2. Hopefully you also know it goes through the sphenopalatine foramen, which I'll talk about in a minute. Then it goes in the nasal cavity, goes down each side of the vomer, encased within the mucosa. It goes out the incisive foramen. And I'll talk more about that nerve a little bit when we do palate. Perpendicular plate of ethmoid bone and vomer form the bony nasal septum. All right, at this point, everybody knows there's three conchae, if you will, and there's three spaces: inferior meatus, middle meatus, superior meatus. And then there's also, here's the sphenoid sinus. So this up here would be where the sphenoethmoidal recess would be. So you will know that the hiatus semilunaris is within the middle meatus. The ethmoidal bulla is within the middle meatus. And then this slide in particular, where you know what drains into what, should be, probably everybody knows at this point in time. We talked about, remember, one thing goes into all of them except for maxillary. So inferior meatus gets the nasolacrimal duct. Superior meatus is going to get the posterior ethmoidal air cells. Sphenoethmoidal recess will get the sphenoid sinus, and then everything else being frontal sinus, maxillary sinus, anterior and middle ethmoidal air cells will go into the middle meatus. So make sure you understand who's going into where. And I'll just tell you, for some of my questions, y'all know I don't tend to always just write which of the following will drain into this meatus. So read the questions, get to what I'm asking. All right, it's really straightforward. I just get bored writing the same old. So, if I said something was blocked up, you can figure it out. Okay, make sure you know innervation of both nasal septum and lateral wall, knowing that always think anteriorly directed is going to be something relative to V1, posterior related will be relative to V2. So for the bony septum, it's going to be anteriorly anterior ethmoidal, external nasal, primarily anterior ethmoidal V1, V2, posteriorly, primarily through the nasopalatine nerve. And same thing for the lateral wall. The lateral wall, anteriorly, again, anterior ethmoidal for V1, and lateral wall, posteriorly would be a little bit different, would be from the lateral nasal nerves. And I know people have asked in here during the lab review about lateral posterior nasal nerves or whatever. For my purposes, I bet neither of these gets tagged on the practice, so you probably won't have to worry about it, is what I would say. Some of the plastic models show the lateral nasal nerves. I think if you said lateral nasal, lateral posterior nasal, I think you'd be in good shape no matter what. But I'm not expecting it tomorrow, or Friday, excuse me. I'll see you tomorrow because we'll tag it all tomorrow. Question? No. Okay. I'm not sure everybody's aware, but when I talk about nasal glands, there are mucus secreting glands, basically snot, that's going to be inside the nasal cavity. And so those glands will receive autonomic innervation. Most of them are going to come from the parasympathetic, the pterygopalatine ganglion. So these are mucosal glands in the nasal cavity that will get parasympathetic innervation via our good friend, the pterygopalatine ganglion. Parasympathetic coming, from the greater petrosal. I'll talk more about that in a minute. But just understand, in the nasal cavity, there are mucosal glands that get parasympathetic innervation from cranial nerve 7 by the pterygopalatine ganglion. Question? Okay. Anybody have any questions about nasal cavity? Yes, sir.
On the outline that you gave us, there's a couple of things that you went into on the outline that you didn't really go into on the lecture, like the blood supply.
Perfect. So the question, if you weren't able to hear, there were some things on my outline that I provided y'all that I didn't go into in detail in the lecture, nor did I probably go into detail about them just now, so I would not worry about it. You didn't see me talk anything about blood supply just now. That was probably for a reason. So we'll go with that. I'm pretty familiar with what might be on the test from these sections, so just listen and learn. Okay, for pterygopalatine fossa, you do need to know boundaries of the pterygopalatine fossa, and really it's in just the general format, like just know what's on this slide. That's just the easiest way for me to say it. So you can imagine how a lot of the PPF is going to be about boundaries, openings in the boundaries, communications through the boundaries, what goes through the openings on those boundaries. Pure and simple, pretty easy. Okay, so you're going to know the pterygopalatine fossa communicates anteriorly with the orbit, laterally with the infratemporal fossa, medially with the nasal cavity, and then it can actually communicate through its posterior wall with the cranial cavity. All right, so we've got the big contents inside the pterygopalatine fossa are going to be the maxillary artery, and then branches from V2, the maxillary nerve, and then some autonomics from cranial nerve 7. So it's knowing what goes through these different openings and spaces. So make sure you're aware of the openings in these. So you know that from this view, you were looking at what? So this was a cross-section, transverse section through, so you would be looking down onto the pterygopalatine fossa. Here's the lateral wall out here, here's the medial wall, anterior, posterior, and this you'd be looking straight down, going into the screen would be going into the floor of the fossa, so going down the palatine canal. So you're going to know the anterior communication is through the infraorbital fissure, going into the orbit. What goes through there, we'll talk about the infraorbital nerve, artery, vein, zygomatic nerve, main things, infraorbital structures. Going through the lateral wall would be the maxillary nerve, maxillary artery. You're going to be aware that also coming back out that would be PSA nerve, PSA artery. So that's the lateral wall. Medial wall, where the sphenopalatine foramen would be, is where sphenopalatine artery, nasopalatine nerve would go through. The posterior wall, so basically this is the sphenoid bone. So you're going to have from lateral to medial, foramen rotundum, pterygoid canal, pharyngeal canal. So rotundum for V2, pterygoid canal primarily for the Vidian nerve of the pterygoid canal. Pharyngeal canal, there's a nerve and artery going to the pharynx, right? Make sure you know lateral to medial, the 3 openings back here on the sphenoid bone for the posterior wall. That would be a very good thing. So again, let's just summarize it. I've probably already gone through it. Make sure you know which wall of the PPF you're communicating with what part of the head. So this just shows them again in different views so you can see all the different openings. Make sure you know them. Make sure you know what goes through them. Make sure you know what they communicate with. If you do that, it should be a very easy part. Maxillary artery in the pterygopalatine fossa is the third part of the maxillary artery. So what are the branches? I think it's on my, so here's the branches of the third part of the maxillary artery. So it's going to be these branches. Remember, there's a descending palatine artery that goes down the palatine canal. There's not a greater and lesser palatine artery at this point. It's descending palatine artery that comes directly off of the maxillary. It will then split in the canal right at its end to go into greater and lesser palatine, but coming directly off of the maxillary is descending palatine. There's a PSA artery, infraorbital, sphenopalatine, and these two little guys, doesn't hurt to know them. I usually don't worry too much about those. It's these four, they're the primary ones I'm always interested in you knowing about. These other ones are intermittent. They may or may not be there, especially artery of the pterygoid canal. Half the time it's never there. A third of the time, probably the pharyngeal artery is not there. These are the ones I'm primarily interested in. I'll tend to test about. So make sure you know those are the terminal branches, the third part of the maxillary artery. So which of the following is not a branch of the third part of the maxillary artery? Okay? Sweet, easy. Okay, one of the big contents also in the pterygopalatine fossa is the maxillary nerve. So here's the maxillary nerve going through foramen rotundum. When it goes through rotundum, it's going to give off multiple branches. So some of them will be where the greater and lesser palatine nerves come off and go down. Some of these will contribute to those lateral nasal nerves you saw. Here's the zygomatic nerve coming off. And what you can't tell from this view is that zygomatic nerve is actually coming out towards you. It's the only one. Just listen to this, it's really for lab purposes, not didactically, not something on the test. But the zygomatic nerve is the only one that comes out in a lateral direction towards you. The others are either going straight down, they're going in an anterior direction. Zygomatic is going to come out towards you because it's going into the zygomatic, it's going to go into the orbit, go into the zygomatic bone, and become zygomaticofacial and temporal. All right? So you can see how it's going to go inside and split into those two terminal branches. So zygomatic actually comes off of V2 itself, as does PSA, and then once it goes through the infraorbital fissure, it becomes the infraorbital nerve. So typically MSA, ASA come off of infraorbital, but I don't want to conflict with anything that he might have said relative to where these nerves are coming off from. All right? For my purposes, just know that these are the branches of V2, and you should be all right with whatever I might ask about it. Let me see what's next. Okay, so a couple of things relative to this diagram, and it goes back towards what I drew and talked about up on the board. So you're going to remember that the nerve, the pterygoid canal, the Vidian nerve, is formed by two nerves. It's formed by the combination, maybe it was my next slide, I'll come back to this in just a minute. So it's a combination of greater petrosal carrying preganglionic parasympathetic fibers of cranial nerve 7, combined with deep petrosal nerve, which contains postganglionic sympathetic fibers that came from the superior cervical ganglion. I won't ask about that detail. Know that these two nerves join to form the Vidian nerve, and when they come into the ganglion, they're coming in along with fibers coming from the maxillary nerve, V2. The only thing that will synapse in this ganglion are the parasympathetic fibers from cranial nerve 7 that came through by the greater petrosal nerve. Deep petrosal sympathetics just travel on through. V2 sensory fibers just travel on through, whether they're going to lateral nasal, palatines, pharyngeal, doesn't matter. The only thing synapsing in here will be the parasympathetic fibers. And then what happens for both the parasympathetics and sympathetics, postganglionically they'll come off and they're going to hitchhike onto all these different branches of V2. Some will go on the lateral nasal nerves to go to mucosal glands in the nasal cavity. Some will hitchhike onto the greater and lesser palatine nerves to go down to palatal mucosal glands. Some will go by this nerve, the pharyngeal canal, to go back to pharyngeal glands. So you get the picture here. Autonomics, I don't care if it's parasympathetic, that's what I'll focus on primarily, versus sympathetic, they hitchhike on these branches of V2 to go to where they're going. The V2 axons in here are purely sensory branches. The nerves are used as a hitchhiker, a conduit, if you will, for the parasympathetics and sympathetics to get to different glands throughout the head. If I go back to the slide before, oops, so a couple things to be aware of. These are kind of showing you those V2 branches I talked about, lateral nasal, pharyngeal, greater lesser palatine. So in this palatine canal, you're going to remember there's a greater palatine nerve that's located anteriorly, a lesser palatine nerve that's located posteriorly, and then typically in between the two would be where the descending palatine artery would be located. Now, it doesn't always fall out like that, but that's what I would tell you to kind of be looking for. In real life, it would be easy because you could typically follow these nerves back to where the ganglion is and know, oh, that's a nervous structure. Versus you could follow the descending palatine artery back to the maxillary artery. I don't know that we can do that in any of these. So for me to tell you where's it coming from, where's it going to is kind of a hard thing. But look for being in the middle would be where the descending palatine artery would be. And then it'll get all the way down here before it splits into greater and lesser palatine arteries. Okay, questions about pterygopalatine fossa? Should be straightforward. Most of it's about the communications and autonomics. Okay, so for larynx, most of this, not most of it, this should be straight for you. We've already talked about the hardest stuff that's going to be on the test. It's all downhill from here. All right? Easy. Sweet Dr. Wynn has never written a hard question for y'all since she's been here. That's not going to change for Friday. All right? So, know the cartilage of the larynx. What's paired versus what's unpaired. If you can't get that question right, it's a bad day on Friday. All right? Who's paired? Who's unpaired? All right? So the unpaired cartilage, you know, is epiglottic, thyroid cartilage, and then the cricoid, whichever way you want to call it. Unpaired would be the retinoids, corniculate. Oh, we don't have that. Oh, so she didn't put the cuneiform up there. She didn't want to show you. So these are the unpaired, the paired cartilages. Unpaired are those other three. And you can see them from the different view. You know that there's membranes relative to these. So if you're going from cricoid to thyroid, this would be the cricothyroid membrane. Thyroid up to hyoid, there's the thyrohyoid membrane. So we'll talk about those in just a moment. So make sure you know here's the thyroid cartilage. On the thyroid cartilage is the laryngeal prominence or Adam's apple. That's part of it. It's not a complete ring all the way around. So when you look at that other view, here's thyroid. It does not make a complete ring all the way around. Epiglottic is not a complete ring. The only paired cartilage that's really only cartilage of the larynx that's a complete ring all the way around would be the cricoid cartilage. People always used to ask the question, if you passed a sagittal plane through the larynx, which cartilage would you touch twice? Cricoid would be the only one. A mid-sagittal plane. Right through here. Cricoid is the only one you would touch twice because it's a complete ring all the way around. Okay, so for the membranes, you're going to make sure you remember that the thyroid, everybody's got this down now. Thyrohyoid membrane is pierced by two structures, the superior laryngeal artery and the internal laryngeal nerve. So make sure you remember those two entities travel through the thyrohyoid membrane. Okay, and then on this membrane, make sure you know that for the quadrangular membrane, that within the quadrangular membrane are the cuneiform cartilages. That's why you really couldn't see them because they're actually enclosed within the membrane, and that the lower free margin of the quadrangular membrane actually forms what's called the vestibular ligament. And she kind of pointed that out down here. Just know that aspect and you're in good shape. All right, so oops, excuse me. So I think what this had to do with is emergency airway entrance. So what I will tell you is, basically this is for the future. Any emergency airway entrance you can create is a good emergency airway entrance. All right? If you can get this person to be breathing, that's a good thing. I don't care where you go through, create an opening, and this person is going to make it. If you don't create an opening, if you're spending their time, so where exactly is the cricothyroid? Because I can't know. Create a hole, all right? Ideally, you want to go through the cricothyroid membrane. The reason is because you're minimizing the potential damage that you create because of nerves and blood vessels that might be present. If you cut through like a tracheotomy, if you come down here and cut through between the cartilaginous rings, think about the recurrent laryngeal nerve coming up through this area. There's some blood vessels that are lying on top of here. Thyroid gland might be in place more inferiorly you go. So there's less chance of damage going through the cricothyroid membrane, but, I mean, hopefully you can palpate it on yourself. It's always good to go home, look in a mirror, try and find out where that is and palpate it. But let's say you've got somebody who's dropped, very likely to happen, and somebody who is quite obese, or somebody's got that linebacker neck that you can't hardly even tell where anything is inside there. You're trying to palpate. I don't feel a darn thing. I can't feel a cartilage whatsoever. Make a cut. Get in there. Okay. So inside the larynx, there's two things called rima glottis and the glottis itself. Okay, so the rima is what? It's the space plus the vocal folds. All right, so the glottis itself, vocal folds plus the rima. Rima glottis is just basically the space. So glottis is the fold plus the space. All right, it doesn't always look like this. So even this, even though it's in an adducted state, that's still, the glottis, the folds plus the space between them. All right. So when we talk a minute about things being either adducted versus abducted, this is what we're referring to as opening up the vocal folds. I want to make sure, because I've heard a couple people talking, and I don't think everybody gets this. So this, just like we've talked about folds, whether it was the palate-glossal fold or it was salpingo-pharyngeal fold or whatever, what is a fold? It's typically a mucosa covering a muscle. Well, in this case, it's going to be the mucosa covering a ligament, and then the muscle will be down below. So when you talk about vocal fold, you cut through this mucosa and you reveal the vocal ligament. And vocal ligament is attached to what? Vocalis muscle. That'll be coming up in a minute. So make sure you know this definition of rima glottis and the glottis and what it represents. So if you know that superiorly is where it's the vestibular or false vocal fold, inferiorly is the true vocal fold. So the ventricle is going to be the space between the folds, and really this gives you a false perception because the ventricle is really, it's a lateral out-pocketing, more so than just a space between them. It kind of goes out laterally. I told somebody earlier today, a better example would have been given you, not that anybody would have cared, but howler monkeys. The ones that really screech really loud or whatever, they have a huge ventricle, and that ventricle extends kind of like down like this, and they may have this pocket, this ventricular sac that they can actually use to create the howling that they do or whatever. So that's what the ventricle is for. It also helps with phonation and the sounds that we can make. So if you think of where the vocal folds are, above them is basically going to be the supraglottic space or cavity. Inferior is going to be the infraglottic space. Some people have asked, what the heck is the vestibule? Vestibule is basically the entryway in, so this area up where we first come in is kind of another term for supraglottic cavity is essentially vestibule, same sort of thing. So it's important to make that separation because sensory innervation wise, you need to know supraglottic cavity versus infraglottic cavity. Because above the vocal folds, I'll talk in a minute, is internal laryngeal nerve. Below the vocal folds, infraglottic cavity innervation, sensory innervation is going to be by the recurrent laryngeal nerve. So you always want to know, are you talking about above the vocal folds, potentially supraglottic, below the vocal folds, infraglottic, because the innervation is different depending upon what we're talking about on those. All right, so go through our slides, and this is a lot like what we've talked about other things. It's always knowing the exceptions. So what's the important thing about cricothyroid? Well, one, its innervation is different from all the rest of the laryngeal muscles. It's external laryngeal nerve. All the rest of the laryngeal muscles are recurrent laryngeal. But also, what does it do? Okay, it's the one that tenses the vocal folds. All right, so when it contracts, it pulls the thyroid cartilage in kind of an anterior, inferior direction. So by pulling it anteriorly, it will change the pitch. It causes a higher pitch tone. So cricothyroid, external laryngeal nerve, and it's one that will tense or increase tension on the vocal folds. So you always want to make sure you know about that. Posterior cricoarytenoid is the only muscle that abducts the vocal folds. Sorry. Hollywood, Florida. Don't know. Used to live there?
Yeah.
There you go. Baseball?
Masters.
There you go. For a good reason. So, posterior cricoarytenoid, posterior cricoarytenoideus, whatever you refer to it, it's one of the few that you can kind of see on the models and things. This one back here, very easy to see, is the abductor, abductor of the vocal folds. Everybody else is pretty much going to adduct or tense, relax, that sort of thing. Posterior cricoarytenoid, the abductor of the vocal folds. Transverse arytenoideus is one that's going to adduct, closes the space, as does the oblique. So as you go through, it's always about what things are different. So the lateral cricoarytenoid, this muscle out over here, functions to close the rima by adduction. So it's another adductor. Almost all these muscles are adductors except posterior cricoarytenoid, right? Remember, all these muscles are innervated by what? Recurrent laryngeal nerve, except for cricothyroid that's been cut off on this side. Tensors. So again, just trying to show you certain things. So vocalis. So we saw that cricothyroid tense the vocal folds. Vocalis relaxes the vocal fold. All right. So here is the vocal ligament. You see how it's attached to arytenoid cartilage, thyroid cartilage. So if you were to tip the anterior part of that thyroid cartilage down, as the cricothyroid does, it will tense, make it a higher pitched sound, versus if you relax the vocal folds, take off tension, just like a guitar string or whatever. Tighten it, higher pitched sound, relax it, deeper sound. Okay? So here's the vocalis. What you don't really get is it kind of sits below the vocal ligament, below a little lateral, but typically there's a mucosa covering it, the true vocal fold. Strip away that mucosa, you see the vocal ligament and the vocalis muscle. Vocalis is directly attached to the vocal ligament. All these other muscles are acting based upon movement of the cartilages, and that's what will adjust tension of the vocal folds. The only one that truly adjusts the vocal folds by being attached to it, a vocal ligament, if you will, is vocalis. Okay. So all these, just make sure you know who abducts, who adducts, who tenses, who relaxes. All right, so I've pretty much mentioned this. Remember, all muscles of the larynx, well, first off, all muscles of the larynx are innervated by the vagus nerve. Specifically, all muscles of the larynx receive motor innervation from the recurrent laryngeal nerve, except for one, cricothyroid, innervated by the external laryngeal nerve. External, as you know, came from the superior laryngeal nerve. But vagus does all muscles, whether it's through recurrent or the external laryngeal. They're all coming from vagus. And then sensory innervation, again, above the vocal folds, internal laryngeal, below the vocal folds, it's going to be recurrent laryngeal. All right, any questions about larynx? All right. So now we get into the part that everybody really knows really well, because I've not had anybody ask me any questions about the next couple of sections. So we'll talk about oral cavity, pharynx, palate. Okay. So floor of the mouth wise, there's a couple of things. So for the next series of things, this always holds true, as I've told y'all from the first exam. If there's something written on the slide, by God, know it. Have I been proven true? Yes. At least somebody say yes. It'll make me feel good. Even if I was wrong, tell me hell, yeah. You know what you're talking about. At least I think I do. Okay. So, you know that there's a vestibule, space between basically the cheek and the gums, if you will. And then the oral cavity proper itself is between basically teeth and the posterior part of the oral cavity, which is where we're going to go into like the arch or whatever. Couple things. So the sublingual fold is this thing down here. I don't think y'all have not heard the term plica sublingualis, right? Just sublingual fold for you, correct? You know, plica people look at me like I'm funny. So you're gonna make sure you understand what that fold is. That fold is formed by, excuse me, the sublingual gland itself. You know, there's multiple little holes on the sublingual fold because the sublingual gland has multiple little ducts that penetrate out onto that fold. That's how the sublingual gland secretes. Sometimes it has a main or chief duct that will go forward, but oftentimes not. And then where this frenulum is, on each side of it is the sublingual caruncle, which is where the submandibular duct will open out into. So you secrete the submandibular duct typically by the sublingual caruncle, sublingual gland, the sublingual fold. Okay, so a couple of things on this slide to talk about. So you know you've looked at there what are called intrinsic muscles, muscles that kind of control shape of the tongue. Let's don't worry so much about that, except when we talk about innervation. And then extrinsic muscles of the tongue, muscles that actually move the tongue. All right. So there's 4 extrinsic muscles of the tongue that are on here. Everything except for geniohyoid. That's not a muscle of the tongue. So styloglossus, got to have glossus in its name. Styloglossus, palaglossus, genioglossus, hyoglossus. So when you look at this, a couple things I want to make you aware of. So one, I think by now you've all seen, styloglossus is the one that's coming from the superior posterior direction, comes down and then blends in with the hyoglossus muscle. Hyoglossus is this fan-shaped muscle, kind of goes straight up and down, extending from the tongue down to the hyoid bone. And then palaglossus will be this muscle right here. So it's a muscle that goes up to the palate and comes down and extends down. And then genioglossus coming from the superior geniotubercle tubercle, kind of this fan-shaped muscle that goes all the way kind of across the tongue, anteriorly to posteriorly. So there's anterior, central, and then posterior fibers associated with genioglossus. So what I would tell you is when you try to think about functions of the muscles, think about their directionality. So these muscles also act as antagonists to one another. So you got 2 muscles that extend superiorly, 2 muscles that extend, if you will, or at least one muscle for sure extends inferiorly, but even some of this too. So palaglossus, styloglossus can be involved with elevating the tongue, pulling the tongue up. Hyoglossus and some of genioglossus will depress the tongue, pull the tongue down, so it acts opposite from each other. Styloglossus is the primary retruder, pulling the tongue back. Genioglossus is the primary protruder of the tongue. But be aware, because of genioglossus fibers, and it even tells you, it's not this slide, it's one coming up. So the anterior fibers will protrude, central fibers can depress, posterior fibers can be involved with retrusion. So 2 muscles, if you will, you'll retrude, styloglossus, genioglossus. One muscle is pretty much the protruder, genioglossus. Elevators, palaglossus, a little bit of styloglossus, and then depressor, primarily hyoglossus with a little bit of central fibers of genioglossus. All right, whatever he's got on here, know it that way, and you'll be great. Geniohyoid is not a muscle that you think about being for the tongue. I probably need a better slide than this one. I may have one coming up, but we're going to remember, especially for lab purposes, 4 muscles attached to the mandible here. Genioglossus, geniohyoid, next should be mylohyoid, going down the hyoid bone, and then anterior digastric, from superior to inferior, those 4 muscles. Yes?
So you're saying that the anterior fibers protrude?
Of genioglossus? Yes.
I think it says that they protrude.
They protrude?
Or is it retracting?
Retracting
And then the posterior ones are the ones saying, protrude.
Because he's saying, it's point of origin, it will, okay, go with what he has on it. What I'm gonna tell you is, no, I'm not gonna tell you that. I've always considered this muscle to be all of it being a protruder, not a retruder. This is the retruder, this is the protruder, but whatever he tells you, go with that, because he's writing the questions, okay? I still don't get it, but I'm all right. I think this got to pull forward, pull forward, pull forward. It's all good.
Unless tip means something different.
Yeah. So anyway, I talked about the sublingual gland, how it's situated. I apologize for saying it wrong from what he had on there. I just have never taught it that way. Submandibular duct, I talked about this. So make sure you know about the gland and the ducts, that sort of thing, where they're going to. So they're already talking about sublingual. When you see sublingual plica, that's sublingual fold. Plica means fold. Thought I'd seen it somewhere in this thing. Okay, so this kind of describes that sort of thing. There's a couple points on here I want to talk about. So again, sublingual gland has all those little multiple ducts emptying out on the sublingual fold. Here's the submandibular gland. Here's the main duct. Here shows the lingual nerve. So you always want to remember this relationship, that the lingual nerve starts lateral, goes inferior, and then goes medial relative to the submandibular duct. Make sure you know that. Okay? So here's the mylohyoid muscle. Maybe this is coming up in something else. This is all about the glands and stuff. Sublingual duct, submandibular duct. I think that's all I wanted to talk about on that. Okay, so what do I want to talk about on here? So I think everybody at this point knows here's the pterygomandibular raphe, interior attachments to the buccinator muscle, posterior attachments to the superior constrictor of the pharynx. You know, it's a landmark for doing your anesthesia. You'll go anterior to the raphe to give an inferior nerve block. So this talks about the directionality of the lingual nerve. I think that's why I put it in here. So make sure you know also with the function of the lingual nerve is going to be sensory to the anterior 2/3 of the tongue, floor of the mouth, and a big chunk of the lingual gingiva, or whatever he's giving you for that. Main thing you're knowing is anterior remember it's just general sensory to the anterior 2/3 of the tongue. Chorda tympani's special sensory taste to the anterior 2/3. That's coming up, like right now. All right, so when you think about sensation of the tongue, you got to split it out into general sensory and special sensory taste. So general sensory is the one that's split into two different nerves. Anterior 2/3, general sensory is by lingual nerve of V3. Taste is by chorda tympani from facial. The posterior third of the tongue gets both general sensory and special sensory taste from cranial nerve 9. And then a little bit of the posterior part of the tongue, and especially the epiglottic region, is both general sensory and special sensory from vagus. Wow, it may come up in a minute, I just don't remember. So while I'm doing innervation, so let's talk motor to muscles of the tongue. Intrinsic, extrinsic, doesn't matter. All muscles of the tongue receive motor innervation from the hypoglossal nerve, except for one muscle, that would be the palatal-glossus muscle. It's a muscle of the palate as well, so its innervation is by vagus, 10. Okay? All muscles of the tongue, motor innervation from 12, except for palatal-glossus by 10. All right. So make sure you understand. So talking to people today, it's always interesting what we haven't gotten a concept across. So you know that there are folds, arches, fauces, different stuff. And I don't think everybody quite understands which are which. All right? So if I do this, we'll do the little magic. I'm going to be ET. So here is a palatal-glossal fold on this side. Remember, what's the fold? Mucosa covering the muscle. So here's one palatal-glossal fold. Here is the opposite palatal-glossal fold. Oh, we formed an arch. That's what the palate-glossal arch is the two folds put together to form an arch. Palatopharyngeus, palatopharyngeus. Oh, we formed a palatopharyngeal arch. Now, in forming that arch, two arches, there's a space between the arches. That space is the fauces. The fauces is the space that communicates oral cavity to oral pharynx. If I'm sitting on the anterior two-thirds of the tongue, I have to walk through the fauces to get into the oral pharynx. Does that make sense? So there's folds, there's some arches, and there's a fauces. Yes, ma'am?
For the oral pharynx, what is the anterior boundary of?
Great question. The question is, what's the anterior boundary of the oral pharynx? So what I want you to think of is the palatoglossal arch is the first part. It's where you're going from oral cavity to oral pharynx. So I know we're going to end up splitting a fine hair because you have to go through the fauces. Basically, you have to go past the palatopharyngeal arch to truly be in the oral pharynx. So your question would be, well, are the arches in the oral cavity or in the oral pharynx? It's the boundary between the two. How about if we think of it that way?
So it would be palatoglossal arch.
Think of it as palatoglossal arch for your purposes, I believe. Okay? So palatoglossal, we got that down. Remember, it's the fold and the mucosa is covering it. It's the it's the muscle when we stripped away the mucosa. You know that between the two folds, palatoglossal, palatopharyngeal, are the palatine tonsils, located between the two. But this gap back here, you're looking into the oral pharynx. You travel through the fauces to go into the oral pharynx. So in this lecture that he did, the best way to think about this, and I may have this out of order and I apologize, but that lecture was really kind of palate and pharynx. He had a bunch of things in there that was directed at the palate and then a lot that was directed at the pharynx. So to kind of separate out the two things, all right? Or maybe I've gone into, no. So here's the palate. Sensory innervation, let me see what the next slide is real quick. Yeah, that'll work. So you stripped off the mucosa so that you can see the different things. But let's go to the next slide. So sensory to the palate. So when I say palate, I'm talking hard and soft palate. Sensory to the palate is all via V2, the maxillary nerve. It's by three specific things. All sensory to the soft palate is via the lesser palatine nerve. Sensory to most of the hard palate is via the greater palatine nerve, except for the most anterior part, which is going to be by the nasopalatine nerve. So this is really for something else than what I just did. That's okay. It's got it in this thing. So again, there's the incisive foramen, there's the nasopalatine nerve. It's sensory to this area in here. All the rest of the hard palate sensation is by greater palatine. Lesser palatine does sensory to the soft palate. Yes?
They call the nasopalatine nerve, whenever it crosses it, like, goes through the incisive foramen?
If you didn't hear the question is it still called nasopalatine? My purpose is yes. Has he ever called it anything? Is he called it? When you think of incisive nerve is really what's in the mandible going to the incisors. So I've never called it an incisive nerve because it's going through the incisive foramen. It's always nasopalatine. But I don't know if that's been taught anything any different.
I think he has it on some of our lab.
It was labeled in the lab.
Yeah. But just like what you see on this slide, this calls it nasal. I've always seen it called nasopalatine. But that doesn't mean, if you wanted to put on the practical, nasopalatine parentheses incisive nerve, how could you be wrong? I don't know. All depends upon if I'm grading it or not. I go, that's not the incisive nerve, it's in the mandible. Just messing with you. Oh my gosh. Don't take me seriously, y'all know that. Okay, couple things about this. I don't think you have to worry too much about the suprahyoid muscles, but what I wanted to point out with this, he made a couple points. Basically, It's all about, do you fix the mandible or fix the hyoid bone as far as what their functionalities are. So you made the big point about you can raise the hyoid, and raising the hyoid bone, you can elevate the tongue. So for mylohyoid, I probably have this coming up on another slide. Mylohyoid is a muscle that forms the floor of the mouth. And when mylohyoid contracts, it raises the floor of the mouth, but in doing so, it can also raise the tongue as well. So you can think of it as being an elevator of the tongue, because it also does that. And you cannot swallow with your mouth open. There's probably somebody in here who can. Can you tip your head? Yeah. Let gravity take it. No, that's just up trickling down. You're not really swallowing. Okay. So on this slide about mylohyoid, make sure you know about it. All this stuff that's on this slide, I would make sure that you know about mylohyoid and the infrahyoid muscles as well. So read through the slide, know the slide. It was the slide about mylohyoid, and it says notes for next two plates. Slide 40, it's got 45 written on it. There you go. See, this says 46. So this is what I was getting to about mylohyoid. It's the floor of the mouth. It raises the hyoid bone and the tongue when we swallow. It can also help open the mouth if we have it work in the opposite direction. All right. The infrahyoids can help with opening them. If you fix the hyoid bone, you can pull the mandible down with the aid of these muscles. They're not the primary ones doing this, but they help. Again, this is trying to show you, here's the lingual nerve, showing how it starts off lateral, inferior, and then medial to the submandibular duct. Here's the mylohyoid. You're going to make sure about this being that retromylohyoid space and the submandibular gland wrapping itself around and coming basically up intraorally. So it's both outside and inside the oral cavity. So I think many of you heard me say this. If you know anything for sure, know this slide and the next one about these compartments. So this would be mylohyoid. Here's hyoglossus. So there's these three compartments. And I know this kind of got messed up when I copied it. So there's a one that's going to be over here between genioglossus of the tongue and hyoglossus. This is where the lingual artery is. Remember, hyoglossus is a big landmark muscle relative to the tongue. There's things that lie superficial to it, the two nerves, lingual nerve and hypoglossal nerve. Deep to it is the lingual artery. So here's this space, and then this space, and then this space between the mandible and the mylohyoid, which is where basically submandibular gland is located at. So what he's got listed here, deep to hyoglossus, that's correct. Between those two muscles, this stuff, and then the third space. So know those three compartments. That's like money in the bank. Oh, let's see. This got to innervation of the tongue. So make sure you know. So it says palatal for pharyngeal plexus, cranial nerve 10 is what you need to know. The actions are listed on here. So this will help you know what they do and what innervates them. Why do I have this on again? That's the same one as before. All right, so getting into pharynx. Let's see. I think I put this one on. You know, there's three parts of the pharynx: naso, oral, and laryngopharynx. So here's where it talks about fauces. So it tells you the fauces are composed of the two arches, and so basically going between the fauces is your communication between oral cavity and oral pharynx. This will be a goodie because there's there's asterisks here. So 3 places where foreign objects might be trapped. So make sure you know this could be potentially the lateral glossoepiglottic fold, laryngeal inlet, and what's actually the third one? Oh, piriform, or, yeah, so this is piriform recess, this is probably, so, yeah. Laryngeal inlet, piriform recesses. You know, the piriform recesses, these little cupped regions on each side of where the larynx is. So these are the piriform recesses right here. So this would be what's called the median glossoepiglottic fold. On each side would be the vallecula. So you can cut, I always used to call the vallecula the crud catchers. You know, popcorn holes and all that good stuff always gets collected right here. If it makes it down into the piriform recess, that's always the bad spot, because you're always trying to move your tongue around. You can never get it to work its way back up. You gotta try and drink a whole bunch of stuff to try and flush it out. And then to get something in the laryngeal inlet, that's a bad day.
Dr. Spears?
Yes,
So are you saying that the lateral glossoepiglottic?
it's really more vallecula. The fold's part of it, but it's the vallecula that are the lateral extensions. Well, vallecula epiglottica, excuse me.
Okay.
Slide before it. On your stuff, it probably lists all the stuff. I'm just saying, man, if he's asterisked these things, better know it. What's on here? So this is the slide. So it says the vallecula epiglottica, laryngeal inlet, and the piriform recesses are those three spots. So make sure you know about those three, and that foreign objects might be trapped there. You know where the palatine tonsils are located. I think that's all I know what's getting to. Yeah, Waldeyr's ring is next. So we talk about typically 3 things as part of Waldeyr's ring, but he kind of gives it 4 things, because there's the pharyngeal tonsil, and then this lateral pharyngeal band. There's actually tonsillar tissue that's embedded within the wall of the pharynx. So pharyngeal tonsil, this pharyngeal band or wall of the pharynx, palatine tonsil, lingual tonsils, they form a ring around each side that forms Waldeyr's ring. So just make sure you know what forms Waldeyr's ring. Okay. All right, so muscles of the pharynx, but I could also do some of the palate here as well, because we got multiple questions about this during the lab review just now. So first off, let me kind of go back a little bit. Here's palate. So here are 2 muscles right here. Here's levator, and y'all have to understand, I'm always going to call it levator belli palatini, so just bear with me. Levator palati, whatever. Levator belli palatini, tensor belli palatini. Yeah, that's labeled wrong. Sorry. That's levator, that's tensor. I'm sorry. Do it because anterior and medial is levator, tensor is the one that's posterior and wraps around, more lateral.
Wait, what?
Am I looking at it from a different view than what I'm looking at?
On all of our lab now, tensor is more anterior and lateral.
Yeah.
Tensor is anterior and lateral.
Okay.
And levator is
I agree that tensor is more lateral. I don't know that I agree that it's, I mean, from this view, this muscle looks like it's medial to me. That's lateral.
I think it's just the way that it looks on that picture.
Okay. I will just shut up and let y'all learn it as you know it. Yes.
When you cover the levator belli palatini with mucus, is it called the torus levatorius?
For my purposes, no. But what's covering it, what you're covering is truly part of the auditory tube, but I'm just going to leave that one alone for now. Interesting. Okay, so let's go to pharynx, as we were talking about. So there's one muscle coming from, here's the torus tubarius, and this little extension that comes down from the torus is the salpingopharyngeus. So then there's a muscle coming from the pharynx that will extend down. That's going to be the palatopharyngeus. Salpingopharyngeus will merge with it, and what you have a hard time seeing, and you probably wouldn't have to know from this view, but there's also a muscle that comes in between the two of the constrictors that will be stylopharyngeus. These are what you call the vertical muscles, the muscle involved with elevation of the pharynx during swallowing. All right? All right, so and then there was palatal palatopharyngeus. Between them be where the palatine tonsil is. So, read through and make sure. You gotta remember, so the vertical muscles of the pharynx are involved with elevating the pharynx during swallowing. So when you swallow, the bolus of food goes to the back of the tongue. You pull the pharynx up so that the bolus can go into the pharynx, and then the constrictors squeeze one at a time, superior, middle, inferior, to push the bolus down. Okay? I'm going to move on. So here we look, I would make sure I knew the constrictors, whatever he told you as far as attachment points. You know, superior is going to the pterygomandibular raphe, middle is coming over to the hyoid bone, inferior is coming over to the thyroid cartilage, and so it's going over these cartilages right here, so kind of know that aspect of it. So what this is getting to, it's coming up in a couple places. All muscles of the pharynx are innervated by cranial nerve 10, except for one, stylopharyngeus, which is innervated by cranial nerve 9. 3 vertical muscles, salpingopharyngeus, stylopharyngeus, palatopharyngeus. 3 circular or constrictor muscles, superior, middle, inferior. All muscles of the pharynx innervated by 10, except for stylopharyngeus by 9. So this kind of thing summarizes a bunch of stuff. Remember, it's pretty much, there's an exception. All muscles of an area are innervated by one thing except for what? All right? Pharynx, stylopharyngeus. Palate, tensor veli palatini. Palate, tensor veli palatini again. Tongue, palatoglossus, because it's by 10. Larynx, cricothyroid is the exception. So if you remember the exception, you're typically in good shape. So he also gave a slide kind of talking about what innervates them. So anytime you see this pharyngeal plexus, because this is all, makes it look like stylopharyngeus gets the same innervation. It does. It all comes from pharyngeal plexus. Just that the constrictors are by 10. These are 10. Stylopharyngeus is specifically 9. And same with that. Oh, and the only reason I put this on, remember cranial nerve 9, motor to one muscle, stylopharyngeus. 9 is sensory to the posterior part of the tongue, taste to the posterior part of the tongue. It's also the sensory arm for the gag reflex. So I think everybody's going to remember that. All right. You know, I did not see that Dr. Rogers gave you her little Quizlet thing that she did. My God, if you know that, you should know everything that's going to be probably coming from her. Just like on oral biology, it should be the same thing. If there's stuff, so I know one thing I was going to talk about. So what I would say, because people have asked, so here's falciform ligament. In reality, this is still falciform ligament. Embedded within it is ligamentum teres. But what I'm telling you for practical purposes, call that falciform ligament, call that ligamentum teres. All right? Yes, ma'am?
Can you clarify where's the greater sac and lesser sac?
Oh, sure. So pretty much everything you're looking at right now is the greater sac of the abdominal cavity. You can't see the lesser sac. Unless you do what's happened here. If you lift up the liver, here is the lesser omentum. So all this stuff hanging down is greater omentum, which is what you see on the models and the full bodies. You don't see this anywhere. So the greater omentum comes from the greater curvature of the stomach. the lesser omentum is attached to the lesser curvature of the stomach, and then it goes up and extends and attaches to the liver. So if you were to pierce through the lesser omentum, or if you were to come over here on the side where the epiploic foramen is, you would go into a small space that's, if you will, deep or posterior to the lesser omentum, which is where the lesser sac would be. Just listen for a moment because it's not rough. So it's all about development, how things come out of either dorsal mesentery, ventral mesentery. And so the bulk of what's happening is all this ventral mesentery stuff that forms a big sac called greater sac. And so typically most of the structures inside the greater sac are intraperitoneal structures, so they're within the peritoneum. All right? We start getting outside of that, posterior to it, you're now getting outside the greater sac and going into a retroperitoneal entity.
So lesser sac is retroperitoneal?
The sac is yes and no, and nothing you have to worry about. Yeah, exactly. Nothing you will ever have to know. So we talked about that. We go on. So one point, maybe it's, I don't know. I may have a slide coming up. I know I somewhere do. So one thing I wanted to point, because I know people have asked about like large intestine, colon versus small intestine. So I want you to think of the large intestine as kind of being like a framework out here. Kind of like forms this, you know, C-shaped structure or whatever. So, you know, because here's cecum, ascending, transverse, we come over and do descending, sigmoid, rectum. And then the small intestines are located in between the large intestine. So when you're looking for large intestines, it's going to be out here on these boundaries, and all the stuff inside is pretty much small intestine. I've not seen anything that shows you got to know duodenum versus jejunum versus ileum, so no worries there. Have to worry about it next week on human biology. So again, know it like she's got it labeled here. In reality, that's all falciform organ. I'll save it coming up. Oh, you won't see this in lab. There's no place where I've seen this whatsoever. So, but know didactically, lecture-wise, that there's this portal triad. Basically, you're going into what's called the porta hepatis. So three things are going in here, or traveling through, if you will. You have two blood supply structures to the liver, the common hepatic artery and the portal vein, and then one thing coming out of the liver being the common bile duct. But they all travel within this entity right here. So there you go, those three structures. Bile duct is coming this way, so it comes down going into the gallbladder, common hepatic going from the celiac trunk, and then portal vein being formed by superior and splenic veins. So again, this is where I guess where I go into. Large intestine, outside. Small intestines, inside that framework. So again, cecum, the initial part. Here's the duodenum, good God. Here's the ileum going in, so this would be the ileocecal junction. So above where the ileum goes in is where it becomes ascending. There's right colic flexure going into transverse colon, left colic flexure going to descending colon, makes the S for sigmoid and rectum. So you can see there's the band for Tania coli. Each of these little appendages would be the haustra, and then all little fatty things, the epiploic appendages. All right, so blood supply is pretty easy. You think about the three unpaired branches off the abdominal aorta: celiac trunk, superior mesenteric, and then inferior mesenteric. You can also do it as hindgut, midgut, foregut, but let's do it this way as well. Celiac trunk gets foregut above, so it's going to get liver, stomach, most of just say liver, stomach, pancreas, spleen. Okay? Here it just shows liver, stomach, spleen. Awesome. Superior mesenteric gets all of the intestines, large, small, except for the little bit that the inferior mesenteric does. Inferior mesenteric gets descending sigmoid rectum. So it's always remembering, what's the part of the intestines not done by superior mesenteric? Descending sigmoid rectum. That's pretty easy. So you're going to remember 3 unpaired branches. Celiac trunk has the 3 branches. That's going to be common hepatic, whatever she referred to it as, splenic, and then did she just put gastric? Did she get left gastric or? Okay. Superior mesenteric. Oh, so what I didn't go into, let me go back. Maybe coming up. Let's see what the next slide is. So the pancreas is a big landmark structure. So above the pancreas is where the celiac trunk is, so superior to it. Coming out directly inferior to the pancreas will be the superior mesenteric artery. And so all these we call the intestinal branches. And this one doesn't show, it's kind of hard to see. I mean, I just pointed this thing down here. I'm not convinced about that. But when you look at the abdominal aorta, right before it bifurcates into the 2 common iliacs, you should see a branch that comes off. That would be the inferior mesenteric. All right. The other thing is you use the pancreas. The artery that would travel right along the superior surface of the pancreas would be the splenic artery. So the pancreas is a really big landmark, especially for the vascular structures in the abdomen.
How do you ID the inferior mesenteric?
Inferior mesenteric, you follow the abdominal aorta down and right. See, here's where it bifurcates into the 2 common iliac arteries. Go back up just a little bit, and you should see an unpaired branch coming off, going to the left. That would be the inferior mesenteric. Some of these torsos, you can see it beautifully. Just look, abdominal aorta, there's the bifurcation for the common iliacs, just a little bit above it. That's where it is. So portal vein, typically it's going to remember blood flow, and this vein is going, it's kind of hard to think of a vein being blood supply to a structure, but it is. So here's the superior mesenteric vein, here's the splenic vein, they unite to form the portal vein. This is the inferior mesenteric, it's highly variable. Most times it comes up and empties into the splenic, sometimes it joins into the Y formed by splenic and superior mesenteric. All 3 of those veins, superior, inferior, and splenic, drain into the portal vein, as a whole bunch of other stuff does too. But splenic, superior mesenteric form the portal vein. And I would know the 3 areas that are varices: esophageal, umbilical, rectal. So basically what that meant was if you get this back up in the portal vein, it causes these different things to occur in the body, because if blood can't flow through the portal vein like it should, bad things happen. All right, so let's talk, this might be one of the last things we do. So autonomics to the GI tract, okay? So it depends if I'm talking sympathetic versus parasympathetic. Sympathetic innervation to the GI tract is going to, or basically the abdominal cavity, let's just say, is going to come from the thoracic splanchnic nerves. The thoracic splanchnic nerves are preganglionic sympathetic fibers that have come from different parts of the spinal cord. So things like greater splanchnic came from T5 through T, so T5, T6, T7, T8, T9. Lesser splanchnic from T10, 11, least from T12. Now understand, these are preganglionic sympathetics that come off, they go right over to the sympathetic trunk, and they do not synapse in the sympathetic trunk. They just travel straight on through. Because what are they going to do? They're going to a ganglion, but where's their ganglion? Not in the sympathetic trunk, it's in the abdomen. Typically associated with a blood vessel, so there's going to be a celiac ganglion. There'll be a mesenteric ganglion. There's a renal ganglion. It's going to a ganglion somewhere in the abdomen, and it will synapse, and then postganglionics come off and go to the different structures they go to. All right? So that's sympathetics from the thoracic splanchnic nerves. parasympathetics to the abdomen is going to come from two sources, either the vagus nerve or pelvic splanchnic nerves. I know this is confusing that there's two types of splanchnics. One is sympathetic, one is parasympathetic. I mean, why they didn't call it something else, you know, who knows. But most of the GI tract, or most of the abdominal cavity, is going to be innervated parasympathetically by the vagus nerve, except for the most inferior part and then down in the pelvis, and that will be by the pelvic splanchnic nerves. And it's all you have to know about pelvic splanchnics. You don't have to know what ganglia or anything else, just know pelvic splanchnics. All right? Vagus does almost all of the abdominal cavity except for the most inferior part, and then as it extends into the pelvis, pelvic splanchnics. Everybody okay on that? Perfect. So, I don't think I put anything in there. I didn't even realize she'd done the head and neck stuff until I saw the thing. One thing. So when you look inside the body, you can see the greater splanchnic nerve. So what I wanted to try and point out to you was this thing right here is the greater splanchnic nerve. If one of these got labeled, still call it the greater splanchnic nerve. But truly, these are the contributions coming from those different thoracic levels going to form the great. Remember, T5, T6, T7, T8, T9. These things come together to form the greater splanchnic nerve. That's the greater splanchnic right there. These are the contributions to it. But if this got labeled, call it greater splanchnic. Ain't gonna happen. Okay? Talk about that. Talk about that. Okay. The stuff that she had in there relative to autonomics of the head and whatever, I would say that's basically just a summary of stuff that you had. Hopefully there's not anything confusing. I'll be more than happy to answer anything about that. The only thing I don't think we've really talked about too much is the lacrimal gland and how stuff came from facial nerve to go to the lacrimal gland. You know, she went through like hitchhikers and told you what nerves they hitchhike on. So if you're going to the lacrimal gland, it will hitchhike onto the lacrimal nerve at a certain point on it, but let's don't get into big detail. It comes from the pterygopalatine ganglion and goes to the lacrimal gland. What else do I need to talk about? We're good? Yes, sir.
The splanchnic, she would just point in there and just say like, oh, splanchnic. Do you think that she wants us to be like greater?
The question is about pointing into, I have not seen an abdominal cavity in here where you could say lesser or least splanchnic. Only thing you need to make sure is that somebody's not pointing to sympathetic trunk versus greater splanchnic nerve. That's my only thing I would say. You see the ganglia for the trunk. Yeah.
More medial would be.
Well, it's more anterior. It's going up towards the vertebral bodies.
Would be the splanchnic.
With the splanchnics. All right. So this is open till 8. Hang around, take a look at stuff. If you got questions, I'll be more than happy to answer. So hopefully that helps.
Thank you.
Thank you.